So, good morning everybody. Apologies for fiddling around here. This computer is definitely not my friend, so something is different than I expected, so no access to the internet, and two actual video clips are just somewhere but not embedded into the presentation. But nevertheless, welcome to another session of Biomedical Microsystems. I like to introduce you today to capsule endoscopy. The questions: why do we need that? What is that good for? What are probably challenges? And why took it that long from the first Nature publication to clinical practice? And I have the Nature publication, pictures from that with me, and I thought I would have the latest presentation, nice video about the latest application of a German company with me, but it's just the cover page and the video has gone lost between the other computer and here. But I can tell you some stories about that later on. So, first of all, an introduction. Why do we need that? What are challenges with standard investigations that have been established over, let's say, the last 100 years in clinical practice? So, what was the medical need? And then some functional approaches, because everybody of us will come to the point, that's so cool, let's do this way and that way and add some more functionalities. That was an idea that was not 20 years old, but about 15 to 10 years old, and created a whole research area worldwide, and nothing has been transferred into clinical applications so far. But other things that have never been thought of, they are really now success stories. So that shows a little bit that you cannot always predict things. One of the already famous German politician who already passed away said predictions are very difficult, extremely, if they cover the future. That's where I can agree. So, first of all, a little bit about the idea of minimal invasive diagnostics and intervention, and then the diagnosis and the therapy as it is today, and standards that we have. So in the early days it was all about open field surgery. So you made large cuts, opened everything, looked in, surgeons could watch, and they could feel. That's quite important, at least in old school medicine, that you can palpate, that means feel what is in there. So if you have cancer in the liver, for example, you can touch the liver and you feel that. The question is, how can you design a technical tool with which you can feel that? It's not only about imaging. Sometimes tissues have a different mechanical strength. You can feel that, but if they undergo imaging, they have this similar content of water or similar acoustic impedance or whatever, and it's really hard to see that in an image. Therefore, that haptics and feeling is still an issue. And the question is, if I don't want to make open field surgery, what can I do? Well, we have natural orifices in our body, and you can try to get in there. But you can imagine, if we look at the whole body from the mouth to the other side, there's a middle part, the small intestine, which is extremely curved, and where it's hard to approach that. And there's one thing one should know. We know all about natural orifices. Surgeons call about surgical orifices. That means they just poke a hole into the body where they want to go. And the question then is, and it seems to be obvious if you make a small hole, that this should be less invasive than a large hole, but it's not only about the holes, it's also about handling. What do you do after making a hole? It's dark inside the body, that's one thing, so you don't see anything. You need a kind of torch or light, and there's not much space. And if you want to see something, you should make some space, for example. That means blowing in some gas and inflating everything, and then the question is, how much can I inflate something before I create some damage? And if we talk about all those beautiful endoscopes, we should memorize that our body is not empty. If we eat and drink something, that will stay somewhere. And if we want to go with an endoscope through the human body, we should keep that in mind, that it's probably not clean and tidied up, but that there is something on the way. I don't know if one of you already underwent endoscopy for whatever medical reason or for preventive reasons. So in my age, above 45 or above 50, you're prone to endoscopy every 5 years, and that means you have to show up at that investigation empty. Means you have to drink 2 liters of really nasty thing that empty you overnight, and then they can watch something doing endoscopy. And this is something we should keep in mind when it comes to, let's make beautiful tools. Every 15 years there's a new idea that you create a miniaturized submarine, call it micro or nano or whatever, that drives through the human body and does things inside there. There are not that good movies from the 50s and 60s about that you shrink persons with a submarine down, that they travel through the body and get lost. And, I've seen more intelligent movies, but doing microsystems, it's sometimes quite amazing to see how people imagine to do that. I'm pretty sure in next years somebody will show up with nano robots being injected, self-assembling, doing things like that. And we always have to keep in mind, what force do we need, how to get there, is it empty, do we have space, do we get things out again, and those questions here. Just a short overview about standard endoscopy to make images inside the body. So you have either stiff instruments with glass fibers or a camera on the top, and you can bring them in with the disadvantage that they're stiff, so you don't get around the curve with them, but with the advantage that you have a handlebar, and if you turn the handlebar, you know where the front is. Disadvantage of flexible endoscopes, well, the advantage is obvious. If I have a flexible endoscope and some Bowden cables, I can probably go around the curve. Disadvantage is if they are long enough and you try to turn them at the end, it's like a watering hose in your garden, you know. If you turn a little bit at the end, you don't know exactly what the front tip does, so in which orientation it is. So you get a little bit lost with that orientation. And you have to handle with that, and you have to take care, but it's really tough to get through all the curves once through the body. And especially in the small intestine, which is highly curved, there's no option to monitor that with an endoscope. On the other hand, there's quite some need. So there's Crohn's disease, there might be bleeding in many diseases, and you don't know where does the bleeding exactly come from. Is the small intestine, is there an inflammation? How far is the inflammation? Many spots or just a simple spot? So it's really hard to get information out there. And the idea was growing over the years. Can't we travel with something through the intestine that gives us information. And that will mean we need some light, we need images, and at the very end, if we see something, we have to know where have we seen that. If you travel through and you say, you have something there, but it's just one spot, and you have no idea where it is, how to find that out. I mean, if you have to do open surgery, then, for example, to remove that, in the worst case, you will just remove that tiny little bit and not meters of the guts. So, already talked about that. So, advantages, it's small, it can travel through, you can get images there. The dream would be really to have something like a traveling submarine that can navigate by itself, that can go up and down if you want to do something, and probably that has a kind of Bob the Builder, a toolbox with a submarine where you can do different things. And different things could be, for example, stopping, holding tight, taking samples of tissue. If you want to do biopsy, well, you could say, well, it would be much more of a dream to have a small genetic laboratory on board, where you could do PCR analysis on the spot or so. But I stopped with that. That would be probably too challenging there. But at least something like, can't we take biopsies there? And do we have some tools that endoscopes have? If I see something that should be removed, that's a kind of a ring, metal ring, you put it around, just pull it apart, and a little bit of electrical current, high frequency current, to stop bleeding, for example. Those were ideas over many years. And of course, the challenges, as I already said, we have to know where it is, our submarine. And I would not be that happy as patient if I have no diagnosis in there that people already do some treatments. If I have no idea what this is, I'll just let us cut out everything that we see. Probably not the best approach. And of course, the more, if you ever have played pool billiard, you know how difficult it is to predict when you bump into something where the balls go. And this is the same if you would have, our intestine is viscoelastic, and if you would have a tiny little capsule or submarine, call it like whatever, and you would try to poke something in there, how do we know that we really penetrate the wall of the intestine and this doesn't act like one of those hits in the billiard? Means our endoscope would be bounced to somewhere else just by trying to poke there with the action and reaction force that we have. And this was indeed one of the challenges that was a bit underestimated. And of course, one of the not that exciting topics always in engineering is the question about packaging. If I have a completely closed system where light can go through but nothing else, so in both direction, illumination and pictures, I can make everything watertight. But if I start now to have some arms or legs, some syringes, some tools, I would need some feed-throughs, either electrical or mechanical, to get those things somehow actuated. Either we have some actuation principles that need magnetic fields, then we would need strong magnets outside, and we have to take care that they are not too strong, that we don't penetrate our intestines, and those mechanisms are sometimes hard to control. There now, I've seen recently this year some really cool clips where people made some new materials that looked like a paper clip, and they were able to walk kind of some centimeters, and they were able to carry a little load and then release that load, but that was very fundamental science, so it was nice to watch, but far from being applicable. And that is really one of the challenges there, how to get functionality without losing reliability and robustness of that. Yeah, and then the question of sensors and actuators, that's manifold. I mean, we can all imagine all metabolic monitoring that we would love to have. Is there glucose? What about the pH? What about whatever inflammation markers that we could see? Can't we do that optically? Then it could work if we come in with a kind of spectroscopy. Electrical parameters are probably difficult. It's all wettish, so it could be a bit of the impedance, but is that enough? That's difficult, especially if you don't know where you are and how close you are. Then it's more the volume conductivity of the intestine that you measure. So really difficult. Yeah, it started, that smart pill concept. It started around 2000 and went to Nature. That was a good trick. Always a good trick, especially in the US American environment, to have high-level publications accompanied with a patent. Then it helps you a lot to acquire venture capital, to commercialize that. That would mean, and this is a bit difficult in Europe. In Europe, you need patents, but investors, first of all, they don't give you so much money. So it's more about small money, but a little bit more long-term, while the US has a different culture where rich persons or venture capital organizations donate a lot. And a lot means it could happen that they just give you to prove that it really works about 100 to 200 million US dollars. Why people are proud here that the average funding in Germany, I guess, was about 150,000 or even less. That means it could be sufficient for development of a digital app or something like this, or a business concept like this famous cheesecake from the market here. That is an idea. I make cheesecake and I distribute it to different farmers markets, which you can do with little money and little time. But if it comes to something like this, I want to generate a technical system that travels through the human body, must be safe, must be reliable, and I have to prove that it's better than state-of-the-art therapy. I'm pretty sure you would need more money to succeed with that, right? And don't want to say more, but in this environment of those US investors, it's always good to come with a high-level publication where you show that it could work in principle. And this is a gift to plan that in a way that those journals like your storyline. So I know, for example, from Stanford University, which is famous for being good and being rich, that they have hired previous Nature editors as support. And if you're there and want to publish, they tell you how to shape your storyline, they tell you how to make your figures, and they cost a fortune. Unfortunately, we are here, Freiburg is not that rich, that we can afford multiple of those persons to support researchers in shaping that. Yeah, just as a side story of science, that you need sometimes really a vision and a long timeline to succeed with that. The idea is you swallow a pill, and that pill takes pictures. That means it needs a battery, since it's not a good idea to swallow a pill with cables. Right? So I've seen many research approaches where There's something wrong here. Either people have no energy supply and they tell you what they all can do without any cable, any battery, and then you have to find out by yourself, oh, that was just the proof of concept without the electronics, or there is sometimes electronics in there, but no energy supply, and then there are hidden cables somewhere. Here, to make it feasible, energy storage with batteries. That's probably one of the reasons why it was not done earlier, because around 2000s batteries got smaller and smaller. We need light, because it's dark inside the body. We need a camera, that is good enough. And we need data transmission. We could also have the option that we store all the data on a chip, but in 2000 they were still too large. So that would be alternative. And then you need an extracorporeal receiver, and of course all that visualization around that medical doctors who have to assess the data that come out, the pictures, have the feeling that they are already familiar with the quality and to support them in a way where they're used, that they feel welcome and they have the feeling they know how to use that. And this computer is not only for visualization but also for localization recovery, that you can know afterwards or detect afterwards where does that picture come from. And this is unfortunately one of the videos that got lost on my way from the office to here. But I have other pictures about that and come later. The company Given Imaging with the product M2A, mouth to anus, that's the abbreviation here. It's more polite in that way, isn't it? So has a length of 26 millimeters and a diameter of 11 millimeters. That is something like a huge pill that is not fun to swallow, but that works with a bit of water. That goes. Weight is 3.7 gram. I can take 2 pictures per second, and the battery lifetime was 6 hours. That is not bad, but that's not ideal, because it goes into the stomach, it stays there, then it goes through the small intestine and the large intestine, and that takes normally much longer than 6 hours. And therefore, other approaches came later on, said, can't we have a delay in there? I'm not interested in the stomach at all, so can't we switch it on after 2 hours or something like that? Can we switch it off in the middle, depending what you want to see? Camera angle is 140 degrees. That means you see a lot, because sometimes that pill tends to move, so it might be orthogonal or traveling backwards, and then you have a wide angle to see those things. And it took that generation in total 55,000 pictures. That's a challenge. A surgeon does not like to go through 55,000 pictures. So you have to make a video out of that, or nowadays you'd say, well, I want to have some pre-processing, that you probably take some artificial intelligence image pre-processing over that you can speed up those things that are a bit boring and stop where you find something. And you need to localize where it is. That means 3 different building blocks. One is about the capsule, optics and illumination, an imager, transmitter and antenna. And of course nobody talked about packaging. This is again a real challenge. You have to assemble everything, you have to package that. The good thing is, if you have a passage through the human body, you can say, well, if it lasts for 48 hours, we're good. That is nice, because a lot of hermeticity or packaging is not it should be a digital concept at first glance, so either it's leaking or not. But if we look a bit more in detail, every material is leaking. That means for the question or the statement of it's watertight always comes with a time frame. And if the time frame is 48 hours, you have a larger variety of materials that you can use that let water and ions come in, but to such a small extent that the electronics is still working. If that should last for, let's say, 100 years, then the amount of materials that we could use would shrink down to probably ceramics and metals. Second thing is the recorder, so data storage. Let's do it the other way around. The antenna sends it out, we have to receive that. Then to process that, central processing unit data storage, and another workstation where you can do more power-hungry data processing, reconstruction algorithms. If you get those data, how can I localize that with certain algorithms? And this is how it looks. Number 6 are the batteries, so there's small cells that you have. 8 was the antenna, 7 the transmitter with an application-specific integrated circuit. And then we had from the front part an optical window, lens holder, LED for illumination, CMOS camera in the middle. So that is the camera, here's the LED, should be 4 here around. And somebody had to assemble that. And that means you can already identify those modules here, the LEDs with 4 around the ring. This is all not rocket science from the single component, but it's a clever idea and very good engineering to get things together in such a modular system that they stick together, to find out, well, what is a clever interconnection concept that I have to bring everything together, that it stays in place, and what do I use for closing the capsule in a way that it doesn't get too hot. So a lot of standard things that are really good for harsh environment systems always come with a high temperature load. Laser welding, for example. It's really cool, it closes everything, but if you do that on such a capsule, you would destroy everything that's in. And that means you have to take standard assembly here, standard soldering, that you can also scale up then for manufacturing, and have to find out what plastic material can I take that survives 48 hours, which comes probably already with a certificate that somebody else checked out, that it doesn't destroy anything, that stays stable and is not toxic. And then, and this is another important thing, they were so successful because they did systems design, not only a single component or working principle, but a whole complete system here. A belt with cables, with battery packs for the receiver to receive all the data here out of the capsule, and those coils had to be glued somewhere over the body that you can triangulate from each and every position where the capsule is. And then, this is a bit hard to see with this light here, computer, and in 2000 computers were still not that large, but not as powerful as today. That was the reason why there was a need of a workstation to calculate everything, and in those days the graphical processing units were hand-programmed still, not as today that you have really racks with GPUs and could do that thing. And you got at the very end here a kind of trajectory where the capsule has gone through the intestine, and when the capsule moved, you have seen those movements, and there was a picture and a kind of length over the passage, and then you could switch the screen to see where am I, what is exactly there. This is here a detailed plot where I can say, oh, this is the picture that I have. This is the previous and the next picture, just in case you see transitional changes of whatever inflammation, for example, in there. You have the passage and the trajectory with a marker where the system would be in there. And this has been done in close collaboration with the medical users to make it in a way that they're happy to use that and that it is a kind of intuitive. So the procedure should be simple, kind of stupid, that both patient and medical doctor or health personnel minimize the handling errors. So there is, hard to see, one page with color coding, and the coils have color coding that you know where to place the coils, right coil on the right spot in the right direction. With self-adhesive stickers. They are not that small to make it possible to monitor everything. Then a hip belt where you can put all the batteries and the processors and all that stuff for that day. The capsule, and this is the capsule holder. This is not mandatory for function, but it's a really clever idea to minimize all those risk and hazard questions. You know, you have to sterilize that if you hand it over. But how should you swallow that pill without touching it? You know, if you touch it or if the medical doctor touches it, there might be again some germs on it, and you don't want to have that. And therefore, there's that blister pack where the sterilized capsule comes with a quite convenient holder here and a kind of rubber ring to keep it in, and then you can take your teeth or your lips and put it out there and swallow it without the germs and touching of a third person. I think that's quite smart. And even if the doctor holds it, the other person can take it without foreign germs, just your own. And then take a cup of water and try to swallow it. So that is the movie that doesn't work. If you go through that nature stuff, and Edurome said me I'm not allowed here to enter. I know where it is, but I cannot. I think I have to throw that computer away. I hope if you got the download that you see it much better here. I can try to lower the blinds. It already shows you that it's difficult with endoscopic pictures here. Contrast is not that ideal. Here we go, I think it gets a bit better here. Yeah. So in that pilot study, it was already switched on when you get it into the mouth. That is the reason why you could see something over the passage into the esophagus, so the tube between the mouth and the stomach. Then you go into the stomach. These are some air bubbles there. you have a sphincter in between the esophagus and the stomach that prevents reflow of that acidic fluid, and this is probably just in the transition that it opens shortly and you see some bubbling there. Then the gastric folds in the stomach, in the middle, and in the intestine the surface changes there. And if there's something, no, we're still down there in the end part, and the large intestine was not empty, therefore the color changes and you see some content there. And that got really viral in 2000, that there's pictures, and then the company grew and got approval for that. And the question a bit is, how far did they go? And this is something I should have, I hope I have the right one here. I have included something at the end to show you not only those old slides, but also the backup to 2022. Where are the companies? How far did it go into clinical practice? But if you look through that, you might ask yourself, well, that's really cool with that camera, but can't we have some actuation in here? Can't we have more for that? And that was, after that went really viral, about 2005, so 5 years later, and people said, we go towards multifunctional approaches. And the wish list here was multiple, what I said before, more sensors, more actuators, more of everything. And the best would be to have something with legs, like an inchworm or something, or a small animal that really crawls through the intestine. And there were a lot of projects, and it happened to me that I got in contact with one of those, so 18 partners. The first thing what they had was a web page. That's always important for the European Union. Before you start working, you should have a web page where you promise everything. And the idea was that we really can have a robotic beetle there to detect cancer, which can locomote, and was really cool. And they were good in graphic design. So I had a supervision of the thesis there and was a bit involved in kind of advice. Unfortunately, I was partner of the other consortium, which was not funded. So there was a competition, and there were two consortia, and one was funded and the other wasn't. I was unfortunately in the other one. Probably for something good, because that didn't fly and I was able to do other stuff in there. So, but you see how compelling that is if you have good graphic design, right? So it always looks like it would work, but it never flew. And the idea is that you can't really even have a better front lens to see even more than 140 degrees. These are again LEDs. Can't we have here some devices that anchor if we want to stay there and see probably some time transition of certain inflammations or something like that? Well, that was probably we start with a cable at the end. And the other is here, can't we integrate some tools? And the most, top one of the wish list was a biopsy needle. Can't we have a biopsy needle that comes out, punches a bit of tissue out there that we can analyze later on? And that would mean you should have the biopsy needle hidden somewhere in the capsule. If you are at the right spot, like old Mars expedition crawl, something comes out, takes the probe, puts the probe in again, closes the lid and travels on. If you would do that with a motor, you would need a lot of energy there, and therefore that approach was, can't we do that mechanically? So having a spring and a needle, and the spring is compressed. If you are on site, just send one electric impulse, click on a relay or something like that. The needle jumps out, penetrates the intestine wall, collects something, and then you need a second spring on the other direction, which draws that back and lid flaps close. That didn't work. And the reason was the viscoelasticity of the inner side of the intestine. So you would have to hold that really tight somewhere to be able to penetrate the inner wall of the intestine. And this brings all those things together, what would be needed. So it's power supply, surgical tools that fit the environment, actuators, a vision system, the communication and sensors. All really cool, playground for microsystems engineering, embedded systems, so whatever you need you could put that in. But it's really challenging with the assembly and with the interaction at the end with the intestine. And there are many more approaches of cool inchworms that go somewhere. Funnily, that whole thing went from that application and then drifted a little bit in soft robotics. I don't know if somebody of you knows those movie clips. It's really one of those hard style ones where you have, it looks like an air mattress with legs, and it's shaped of many chambers, and it has 4 limbs. Imagine an air mattress with 4 limbs, and you can, like an inchworm, you can buckle and then release, and then by releasing and buckling and releasing and buckling, you move forward. And while taking a movie clip, whatever car or motorcycle or wheel comes and runs that soft robot flat, and then it gets inflated again and crawls further on. That's one of the advantages of soft robots, if you have them in a proper manner, that they are not made out of screws and levers and whatever that can be destroyed, always comes with that movie comes another one where you have an octopus, and an octopus can squeeze through a very small hole since it has no skeleton. And this is also a kind of wish for soft robotics. In some cases, of course, there are other soft robotics that work differently, and this is also envision, can we use that for making something useful inside the body? So let's say the necessary next generation of those approaches here. But still far from being applicable, still in the very fundamental research, but nevertheless something comes out, and probably the application is completely different to what has been expected. Here it was about stomach cancer. So making devices small, if you want to have triangulation, you can have a lot of coils outside, or if you don't want to have those 8 or even more coils outside, you'd say, well, can't we do that? That we have internally 3 coils, 1 for each direction in a Cartesian coordinate system that is shown here, Z, X, Y direction, for example, and can't we get the information out over those coils? On the other hand, if you want to have inductive powering, it's always good to have the maximum power out of the electromagnetic field, and if the electromagnetic field comes from one direction and your coil is not perfectly aligned with a cross-sectional area in that direction, you don't get so much energy out of the field. If you have 3 coils in 3 directions, no matter where the field comes, you could harvest much more. Then it came about data acquisition and telemetry, and you don't see much, but the take-home message I would give you is always ask for a scale bar. If we talk about small systems, sometimes they're manufactured to show that the principle can work, and if you look on the scale bar, it's still then a multiple of the final size that would fit into the human body. There are many cool applications that got killed at the very end because the transition to the size of the human anatomy did not work. There are other applications where people were completely right, where they said, you know, I study the general concept, and when I'm there, technology will have evolved, and it's miniaturized, and I can do that. It worked out in some things, it didn't work out in others. Locomotion, that is for me still one of the miracles there. So what people can imagine here, a legged version with, I guess, 8 legs with hooks that you can crawl. Then if you look on the anatomy, that's quite challenging. The esophagus have to lie probably 2 centimeters, 1 to 2. The stomach is much larger. And then comes the small intestine, probably 2 centimeters in diameter. Large intestine, 4 centimeters in diameter. Very flexible, can expand. So you need legs that are small enough that they can get in line with the capsule that you can pass. And they are large enough that you can anchor to whatever wall is like boulder championship or something like that you get fixed, where that you can hold tight wherever you like to. So this is with arms. The other approach that has gone very far is the idea of the worm-like approach, that you have here some cushions that can be filled with something, either with air or with fluid, that gets smaller and larger, and that you have then kind of inch worm filling that you can propel with that. There are also approaches where you have a propeller, like a submarine. The nano world now works with flagella. Means you have proteins, like a tail, and that tail rotates, and then you can drive nanoparticles in a preferred direction. So really cool stuff from the fundamental science side. It gets a bit difficult in that translational process where you have to make it robust and reliable for medical devices. And then there were thousands of other challenges here. And please do not forget the users. That's very important. Users are adapted, or users got, as you get an education, other users get other educations, and they're trained in that. And if you're trained in a certain way, you cannot imagine that some new devices don't survive your handling. And this is very important. In stiff endoscopes, the main failure case is for thoracotomy, that means investigations in the thorax. I heard that from somebody who worked with endoscopes, that some of the surgeons, even though it's forbidden, use the endoscope to lift the skin over the rib cage, like a lever. That's something an endoscope is not made for. But it should survive that, otherwise those guys and girls go to another company. That means all endoscope companies now trying to make those endoscopes as stiff as possible, as robust as possible, that they can be used for something they never made for. And that is also true for other applications. Might it be implantation of technical devices, that the understanding of a medical doctor is different than the understanding of an engineer, and things that seem to be obvious for the engineer are not on the screen of the surgeon, and the other way around, you know? Where surgeons say, it's obvious that there is a blood vessel there, where the engineer has no clue that you should consider that blood vessel, or something like that. So therefore it's very important to talk from the very first day on, and to co-develop that in a way that you find the right partners with whom you can discuss all these things. So now the update. We have different things here. The good thing is, given imaging is still around in 2022, it's not always the case that the company who invents something is still there. They can be either bought by other companies or they are bankrupt. In that case, they're still there. Olympus, as one of the microscopy companies worldwide, has jumped in, and other companies made also developments there to enter that market and get a market share. There are differences here in everything. The size and the length is varying, the weight is varying from 3 to 6 gram, battery life from 8 hours to longer, depending how many pictures you take. Resolution varies, frames per second are close, field of view is also the similar range. 3 of them use radio frequency communication, 1 has an onboard storage, and 1 uses whatever type of human body communication. So that means you can use the tissue to transmit data and collect that. I didn't check that up, what kind of human body communication that is. So it means it's good. This is a nice review. This is for small bowel investigations. It was mainly about inflammation, that whole stuff, and they made gazillions of tables in that review where they assess or evaluate one camera against the other, if it works for that medical circumstance or for another one. If you want to look into detail there, that DOI directly guides you to that free download. I can try to upload that also on the Ilias page, then you have it there. My PDF is already on my desktop. So if you like, you can have a look into that. Yeah, that's the downside. And probably it's yeah, this is the downside. This is only here that cover page, but I can give a story to that and kindly ask you if you Google Ovesco and switch the language to English, you have all those movies there for free download from that company site. I find that a very good storyline. Apologize that video got corrupted while transporting it from one computer to the other by copying. Checked it on 3 others and it worked. They made a market research some years ago, let's say 5 years, 6 years, 7 years ago, when no, it was longer, 10 years ago, when all that hype about equipping imaging pills with a lot of stuff was really high. And they found out, well, this is so difficult, would be nice, would be like the fastest car on Earth, or diving to the deepest point in the sea. But most of the patients who are prone to those investigations have bleeding. So if I know that I look for bleeding, I would not know anything else but a sensor that looks for bleeding. That was their idea. Sounds a bit stupid, but it was completely the opposite to what all others did. All others did more and more and more and more, and they said, no, we try to reduce that. And bleeding means we have to detect blood. Blood has a very particular absorption behavior in the infrared range. So if it's oxygenated, it has a different absorption behavior than deoxygenated blood. You know exactly at which wavelength you should look at, and those wavelengths, all the other stuff that is in there is more or less transparent to those wavelengths. That's cool. So you just detect blood because you know that somebody is prone to bleeding. If you go to the doctor at a later age, you get a free investigation per year if you have blood into your stool, right? And if you have that, it would be good to see, well, where does it come from? Is it somewhere that you can localize that part of your intestines where it could come from? And that was where they started. Once heard a talk of that guy, but he did not share the slides. So the first prototypes were really garage-like. So they had two light diodes and some boards, some breadboards to place all the components, and then they took a droplet of blood and said, hey, this is blood, and then they took a lot of other things and said, oh, no detection. And then they integrated that and really made it to the market in a relatively sharp timeline. Having these things now with a portable system, all tablet, computer, things like that. And the pill is as large as the others are, but much more specific to blood. That means if you know, I don't want to have a general movie, but I know where I'm looking for, this could be an application which is cheaper, because there's less electronics in there, and more specific. And that is a really cool one. That was what I wanted to show you here. And of course, I'm quite happy that this is an approach that was developed here in Germany for Europe, which shows, and that's not because I'm German and I'm proud that everything comes from Germany. That's not my take-home message. My take-home message is that you can develop medical devices in Europe in a time frame that is still about 10 years from the idea to the CE mark. So the approval that you can do that under those relatively strict legislation to ensure highest level of safety, if you know what you want to do. And this is very important, and it's important that you first prove the concept, and that you then have not only engineers or physicists on board, but management persons, quality management, regulatory affairs, all those things that are a bit annoying for engineers if they want to play around and if they want to make cool things. But that's very important to consider that from the very first day on, that you do not do developments that got stopped at the very end. I've seen one development that was really a pity. There was a delay of 2 or 3 years where people were nearly ready to go with a foil-like ECG recorder, and it worked perfectly well, but unfortunately they've overseen minimum distances of voltage carrying lines for those applications, and they missed half a centimeter or something like that, and they had to start from the scratch to do all the investigations again. If you have that in mind, you browse through, you get a bit advice from agencies who are good in that, and then you can do it in a, let's say, 10 years time frame. It doesn't go faster. That's the downside. Average development time from medical devices, implantable medical devices, from the idea to the CE mark is still 12.5 years. And that is not because people are so slow and don't want to work day and night long, but you need a lot of investigations there. As I've shown you in one of the first lectures, if you have something that works, you have to see, can I sterilize that? Does it really work? What about packaging? Does it work after transport? All those things take its time, and it's important to have that. Otherwise, you might get stopped when you have something on the market. I think it's not only better for reputation, if you look on the money you need, it's much better to make mistakes in an early stage that cost you less money than making mistakes at a late stage, because having mistakes at a late stage means you have to jump back to start and do everything again. Yeah, that was my time filler instead of that movie. I have it somewhere. I tried to upload those two movies and the lecture later on, that you find everything on the Ilias system and can browse through if you like to. So to summarize, this is here what the lecture has made of. So old data, some web links, and new data, a review on wireless capsule endoscopy. And reviews are always good. They are meta-analysis, so they rely on, don't know how many, 150 papers, so you don't have to read 150 papers, but just browse through one to get an insight there. And that was also one of those who published open access, so that the costs are not with us, but with them. Open access publication could be another lecture about pros and cons of that. It has been invented to make research more accessible, which is a good idea, that everyone all over the world has access, because the criticism was these journals are so expensive that non-rich universities or countries where the average income or whatever amount of money is not that high can afford that. That is good. So we have now free access. But, always another side, if you want to publish, so if you are doing the research and want to publish, you have to pay for that. Currently, there's a transition period where some journals want to switch from one to the other. So the non-that good journals, they're still decent ones. They are, let's say, about 1,800 euros per publication. There are others that are more towards 2,500 or 3,000 euros. And Nature just rose as one of the highest ranking journals. They entered that discussion saying, hey, we're so good, we're so important, we're at least as good at 3 other publications. So if you want to publish something with us, we think 10,000 euros is a good number. It's still under discussion, but I mean, if we think about that, we're now at a situation where we can all read that for free, but if you do research, it depends on the amount of money that your institution has if you're able to publish that or not. And I think this is probably not a good idea to establish a balance and equality from the global north and the global south to get research better out there. So we're currently still at that situation which is as bad as it was before open access. That very personal opinion about that, but I think if you have to pay so much, it's not a good idea, because you need some business models, and the first journals are starting those business models that your amount you have to pay depends from the country where the research has been done. So that certain countries don't have to pay anything or have to pay less, just kind of handling fee that is more affordable, and the rich countries have to pay more. As usual, if you have something like that, I'm pretty sure that the first persons are already thinking about detours, how to save money, right? So having a good collaborator as submitting author who sits in a poorer country than you are, or something like that. Let's see, but things are going on. That was just an excursion in publication options and fees. This one here is for free, and I put it on the Ilias system. So, to summarize the take-home messages, first of all, we have now something, the wireless endoscopy, with which we are able to monitor the small intestine. Clinical products have video recording and data transmission. Actuation units are still under investigation for now more than 20 years. I have to see if something pops up that's reasonable. And the major challenges include the energy supply, the miniaturization of the packaging, and of course, not written here, the sensitivity. So what do I want to image? What do I want to get, as now discussed here, picture versus blood. This is a difference, and I think if we carefully watch the development of different applications, we will see more things popping up for very particular applications. So with that, due to the lacking videos here, I finished a bit earlier than scheduled. I think given the temperature in that room now, entering and coming closer to the boiling point, you would not mind to stop now. Thank you very much. We hope to see you under less warm conditions, still sunshine, but probably not 38 or something like this next week. Thank you very much.